today we'll be discussing an important topic, especially with regards to even diagnosis, because it's a very loosely used term. That is vascular malformations, vascular tumor. I've seen perhaps whatever reports I see, everything, the diagnosis is given as hemangioma. So whatever kind of malformation anybody sees, finally they will write, these lesions are seen, cystic areas are seen, flow is seen, query hemangioma, which is maybe fine for the some of the clinicians who also don't know and only need to refer things ahead. But somebody who wants to treat or wants to take a decision of treatment, then just writing query hemangioma, query vascular tumor is just not enough. You should be very clear what you are trying to state when you are telling about a vascular malformation. And on the way, we'll also discuss what are the treatment options for each that we can offer, especially in low flow venous malformations and AVMs. Today, I'll be covering till venous malformations and hemangioma or vascular tumors and the basic classification also. And then in the second part, we'll be going to the arterial malformations and lymphatic malformations. So, as I said, basic introduction and the classification scheme and which modalities to use in the diagnosis, what to start with, and then what is the final definitive imaging. That is important. Then we'll start with the vascular anomalies one by one and talk about the possible complications, how they increase in size, then decrease in size, or they continue to increase in size, what all problems can happen if they are left untreated, and what are the treatment options for each. So as I said, vascular anomalies is just deviation in the cutaneous or the deep vasculature, can be congenital or acquired, and it's a very heterogeneous group of diseases, and we need to understand exactly what is happening. So they were classified by various people, in from 1860s, some kind of classification is being formed. Then 1982, Mulliken Glowacki gave a classification which continued for quite a few years. Finally, the International Society for Study of Vascular Anomalies gave a classification, or the ISWA classification, in 96. And in 2014, it was revised, and that's what we'll be focusing on. So basically, they divided them into vascular tumors and vascular malformations. So tumor will have a basic nidus or a cell proliferation apart from the vascular channels. So if there is a proliferative area of cells also, then it would be a tumor. Otherwise, if it's just a tangle of vessels, then it is a vascular malformation. In tumors, you can have both benign, locally aggressive, and malignant tumors. Whereas in malformations, it is primarily based on what kind of vessel is involved. So is it capillary? Is it venous? Is it lymphatic? Is it arteriovenous? Is it a fistula, or is it a proper malformation? And sometimes we will see a combination. It may not be simple. See, it may have both a venolymphatic component also. So the basic idea between vascular tumors and malformation is that vascular tumors have a higher predominance for the females, but in vascular malformation, both males and females have a similar distribution. As I said, cellular proliferation is important. It should have a mass-like structure associated with it, whereas malformations are primarily just dysplastic vessels. Both are usually present since birth. Vascular malformations are usually present at birth, whereas vascular tumors may be initially small and grow with age, or they can be partially developed in the beginning and then maybe even fully developed. So there are different ones which may be fully developed at the birth, or they slightly grow after the birth over the next few months or years. And vascular tumors, which we'll be talking about, the hemangioma especially, they rapidly grow in infancy and start involuting in the childhood. Whereas malformations, they will be continue to increase in size as the patient grows in size. So the growth is proportional to the patient, whereas vascular tumors might initially grow and then involute, or perhaps sometimes just become static. So conventional radiography, there is very limited role, especially if you see something on the X-ray, there are phlebolytics, you can suggest, or there are some periosteal changes or some bony changes which can point towards uh, further imaging. Ultrasound is the initial workhorse. Basically, it helps us in defining a lot of things which we'll be discussing. So that is one of the most important initial modalities. Contrast enhanced CT sometimes is done to understand what is the feeder vessels, what are the draining veins. But the primary definitive modality is MRI. So the initial workhorse, initial imaging, ultrasound. And if you really want to understand the dynamics, what phase it takes up the contrast, is it taking up contrast, how is the washout, what is the anatomical arrangement, is it subcutaneous, is it going into the muscles? So all that is very nicely seen on the MR because the tissue differentiation is so much better. And conventional angiography is usually done once we have an idea of the diagnosis and we are trying to understand the anatomy, especially in complex AVMs, and then further for the treatment. So as I said, conventional radiography, limited role, but you can see there are some phlebolytics in this area. So if you see something like that, maybe you can do an ultrasound and try to figure out here also. Sorry, the pointer is not there. Yeah. So this area here, you can see there are some phlebolytics in this area. Then this index finger, you can see some soft tissue density and phlebolytics inside. So these are the usual areas of this kind of malformation. So you try to keep in mind and maybe you go for the further imaging. Sometimes there can be a periosteal reaction, a slightly more aggressive vascular malformation. You might end up having pathological fractures also. So as I said, duplex ultrasound is the first modality that we will use, and we should be, it's an operator dependent thing. So it totally depends on how well you know what you're looking for. So if you know ki I am to differentiate these things, then only you'll look for them. Whether it's a tumor, you want a more solid lesion is there, or is it just cystic spaces? Then what kind of vascularity is there? Is there a lot of vascularity, no vascularity, or mild vascularity? Then you put your power Doppler and you try to see whether it's arterial waveform or there is only venous waveform. If there is arterial waveform, is it just one vessel or there are multiple vessels? So is it a really high flow one or is it a slow malformation? Also in venous, if there is a lot of arterial waveform in the vein also, then it means that it might be a fistula that might be present, that there is a direct arteriovenous connection, and as it is you are having a lot of blood flow going from the artery into the vein directly. So the advantages, as I said, very easily available, inexpensive. You can go and see all these things in real time. So if somebody has a lesion which is quite accessible in anatomy, easily ultrasound can be done. Then it really gives us a lot of information. Then MRI is primarily for confirmation and to see the extent, but most of the things you are able to tell on ultrasound. So you have to differentiate between high flow and low flow lesion. You have to tell whether it's a deep or a subcutaneous or superficial lesion. And then you can think about an MRI later. As I said, CT, you can see this kind of fatty infiltration in this area and some phlebolytics. So this is also a malformation that was present in this patient, but again, very limited understanding the tissue contrast that is there if CT is not meant for these kind of things. So as a result, we try to go to the MR directly. In vascular malformation, yes, that solid component is usually missing. So that's what you have in a vascular tumor. There's a cell proliferation is there, whereas in this, the tissue might be there. There may be some fibrous tissue around. A nidus might be there, but primarily a proper cellular differentiation and a tumor-like cells are not there in a vascular malformation. So capillary ones, may not look like vessels. If it's a capillary malformation, it might look very small. But frankly, inside the tumor, their cells number apart from the endothelial cells and all is very less. Whereas in a solid tumor, you have proper cellular component. Then when you go to MR, that is the imaging modality of choice. Finally, soft tissue discrimination is really good. You're able to tell where the lesion is extending, what is the extent, is it a single, is it multiple, are they connecting with each other, or it's a multifocal kind of lesion, is it going into the planes, or is it subcutaneous? You can make out really well which muscle is involved, which is not involved, because if somebody is planning a surgery, then you need to be able to tell which muscles are involved. Then they'll be able to plan if there will be a functional deficit if they are going for surgery. Which is the last slide? I am not sure that they are talking about.